basically what you're going to see is that hip fracture is the most common injury in older adults. It's frequently the most frequently seen injury in any healthcare setting. One of the things that you'll see, especially in your elderly population, is very high mortality rates, and that's often due to multiple complications of surgery, depression, prolonged immobility, and their comorbid problems like the diabetes, the heart hypertension, the cardiovascular disease, the kidney injury, okay? And as we said yesterday, a high percentage of them, maybe up to 50%, die within 1 year after injury. And the older you are, the more likely you are to have that fatal outcome. Now, one of the things that you'll see, just again, a little A&P, the head, the neck, intratrochanteric and subtrochanteric region of the hip. Those are important because one of the things that you'll see is that it makes a difference where it's broken as to what kind of injury that you get. It also makes a difference in the blood supply. So if you have intracapsular, okay, meaning that it goes across the neck of that hip or down here, then what you're going to see is that it can be very bloody, and it often impairs blood flow to the femoral head. And what happens is that if you have decreased blood flow to the femoral head, you can have necrosis of that, and you might have to see a replacement because of that. Now, extracapsular, basically you're going to see a defect in the blood vessels themselves. Okay, so what you're going to see is this is not the head or the neck region, it's actually on the hip bone itself. So what you're going to see is that acute blood loss, and what you might find in your elderly patients is hypovolemic shock. Okay, looking for that swelling, looking for that bruising, keeping an eye on their blood pressure is very, very vital, because with hypovolemic shock, we see hypotension, tachycardia, tachypnea. Okay. Now, some of those tips, you might see the tachycardia and tachypnea because of pain, but you will not see hypotension because of pain. You see hypertension. What you often see is these risk factors: decreased bone mass, or that osteoporosis. You might see a higher propensity to fall because of that unsteady gait, their balance. Or it may be neurologic, like your patients with dementia that can't remember that they're not supposed to get up at night. Visual and musculoskeletal impairments. One of the things that you often see is that people with visual impairment, i.e. low vision and or impaired vision from like cataracts or glaucoma, are at risk for falling because they cannot fully take in their environment. Lower body weakness and musculoskeletal impairments also increase risk. But look at this, taking 4 or more medications or any psychoactive medications. How many of you have taken care of elderly patients that are on no meds or only one med? Probably no hands. Okay? Any of you ever been on IP, internal pulmonary? Okay? You've got a treat coming. I will tell you that I have taken care of patients on there that have taken 30 different medications. And I have never seen a student cry as hard as they came into prep and had 35 meds, and their patient was discharged the next day. And I said, honey, don't worry about it. I'll give you a patient that has those same meds. And I know that I can do it because what did Dr. Kelly's patients will always have those pretty much same meds. But you're going to see a lot of medications. 4 or more meds. The average elderly person now takes 6 to 8. And often what you're going to see is that
She thought you said 68.
No.
I was like, no,
6 to 8. Okay? And that's not including many nutraceuticals that they may take or over-the-counter medications. That's 6 to 8 prescription meds. And a lot of times what you see is called polypharmacy. A lot of times what you see is they take meds to counteract the side effects of this other med. Why don't you take them off that med and try something else instead of giving them something for side effects? Anyway, a lot of times because you have a cardiologist, you have a kidney specialist, you have a general medical practice doctor, and then you have someone else that looks after something else. You have 4 different doctors, and if you don't look at the different medications each of those physicians are giving you, then you're going to have problems with interactions with some of those patients. You know, one of the things that you see in a lot of elderly patients, if they don't have prescription coverage, is they will shop different pharmacies to see, I can get this med cheaper here, and I can get this med cheaper here. Well, they're not the same chain, okay? So they're not in one computer system, and this pharmacy doesn't know that I'm taking this medication. And often what you can see is they are counterintuitive or counteractive to each other, or together they can have a much higher side effect. It contributes to fall. Okay? So, clinical manifestations of a hip fracture, and this is a KDOD. They may be unable to walk, stand, or bear weight. They will have acute pain. And this is what you need to remember. The affected leg appears shorter and externally rotated. With a hip fracture, classic sign, shortened, and externally rotated. Okay? What you often see is that we treat them with that box traction and mobility, and then they do an internal fixation. Risk factors: increased age, female, osteoporosis, decreased estrogen, and you may see falls from all of these causes. Our nursing priorities are hydration, respiratory support, circulatory checks, because we definitely don't want that box traction cause compartment syndrome. We want to prevent immobility complications. And if you've got a history of chronic conditions and meds, make sure that those meds are appropriate for someone that's pre-op. Typically, with your elderly population, you're going to see either an antiplatelet, an anticoagulant, and or aspirin. They may be taking NSAIDs for arthritis. All of those medicines have to be discontinued prior to surgery because of increased risk for bleeding. Okay? So we need to make sure that not only are those discontinued prior to surgery, but they are started back at appropriate time period after. Because if I'm taking aspirin and Plavix to prevent TIA, I don't my leg would stroke out. Okay? Make sure that those are done appropriately. Typically what you're going to see is that with hip fracture in your elderly population, it is one of those things that start causing flashing lights in the case manager's office, okay? Because what you see is that this is one of the things that we are going to follow very closely with case management, because it is one of those diagnoses that you're going to follow, okay, with your case manager so that we can get them in, get them out, or appropriate rehab if necessary, or home care. Because what the hospital does is that if you have someone, an elderly person with a hip fracture, Medicare will pay this much, $50,000 or $60,000, depending on the area. Okay, so that if my person is in the hospital and they do well, and they do well with surgery, and they're able to go to their rehab, and I've only spent $40,000 on their care, then the hospital's made $10,000. But what happens if they don't do well, we don't follow what the standards of care for this patient, or they have a complication, and it costs $100,000 to care for this patient while they're in the hospital. Medicare still will only pay you $50,000, so you've lost $60,000. This is one of the high volume diagnoses that are covered. Social work or case managers, your interdisciplinary team definitely need to be contacted. Now, some of the diagnostic tests, bone mineral density test, if you've got someone with osteoporosis and they fractured a hip and the bone is too fragile to hold the hip replacement, then often they will not do a surgical repair because they know that that fragile bone is not going to be able to hold that implant. And that's unfortunate, but sometimes what you'll see is that surgical repair is not always possible. They will do MRIs, bone and joint scanning, ultrasounds, etc., just to make sure that those are done. Skin traction, we've talked about. This is basically what lux traction looks like. It's in a splint, and there's traction here. The weights are hanging off the bed, remember, about 5 to 10 pounds. It's to prevent muscle spasm and decrease pain prior to surgery. The goal of that surgery is to reduce and stabilize the fracture. Most time it's an ORIF, open reduction, internal fixation. Now, they can do hemiarthroplasties or total hips, or they can, hemiarthroplasty basically is they either replace the head or the neck, okay, or the hip portion of it. Total is they replace both the cup as well as the hip replacement. It's commonly done whenever you've got severe osteoarthritis, okay, or there's a fracture through the neck. This is what you might see. This is just instrumentation to completely fix that hip fracture, and you can see the screws going into the femur here, and that just stabilizes that fracture. You can see this one with the 2 rods, but this is what you would see with a hip replacement. This is a hemi, because what you've got here is just the hip portion of it, not the cup that holds that ball in place. I have to remember office that I use as a hammer sometimes. Because it's heavy enough to use as a hammer. Preoperative teaching, you need to know what their health history is, their physical assessment. You need to explain and practice post-operative activities. Respiratory hygiene procedures, in other words, turn, cough, deep breathe. I don't know why they call it respiratory hygiene. It's turn, cough, deep breathe. Post-operative care, vital signs, pain, neurovascular checks. Look for incisional bleeding and reinforced dressing is needed. Typically, these posts will come back with either a Jackson Pratt drain or a Temovac in place to make sure that there's no bleeding internally. Maintain proper positioning of that effective extremity. Remember, we want it in a neutral position with no rotation. SCDs or anti-embolism stockings as prescribed, and I work with a lot of orthopods that like both. So we need to make sure that they are appropriately cared for to prevent DVT. Now, positioning will depend on how they would place it. Okay, you might see that the hip is kept in that sort of neutral position with some elevation. Typically, you will see if they're on their back, they'll have pillows in between because you don't want that leg to cross the midline. Okay, so you want to have that slight separation. You want to make sure that they follow what their hip precautions is. And how can I tell if that hip does slip out of place? What sign am I going to see? Shorten leg, external rotation. Okay? That's a call from the doctor. You might get a cussing. Some of your nursing diagnoses, acute pain, risk for peripheral neurovascular dysfunction, risk for infection. Those are going to be your priorities. Impaired physical mobility, basically one of the things you're going to do is consult PT to help them move and to learn their precautions. And then you might see disturbed sensory perception, tactile. They may have some numbness at the incision site that may not go away. Fall prevention. I mean, this is stuff that you guys have learned ever since you were in school, but it's one of those things that we keep harping on you because falls are not the most wonderful things to happen to patients at home, but certainly not in the hospital because the amount of paperwork you have to fill out is ungodly. But the amount of people that do fall and fracture their hip is increasing, and it will continue to increase as our population ages. So just take a look at these and keep them in mind. Now, with the hip fracture, this is it in a nutshell. Okay, so make sure that you understand each portion of this. Now, OA, osteoarthritis. Remember, whenever Ms. Beaver talked about RA, it was a what type of disease? Autoimmune. Osteoarthritis is a use and abuse type of disease. Think of it as someone uses that joint frequently, like nurses or beauticians that we stand all day long. Think of it as someone that got a lot of pressure on your joints, okay? One of the things that I will tell you is that one of the best ways to prevent osteoarthritis of the hips or knees is to maintain a normal body weight. Even a 5 to 10% reduction in body weight will decrease the impact on those knees and those hips. So weight loss is one of the things that we talk about with people with osteoarthritis. Typically what you will see is that it is a degenerative joint disease. It's localized. You may only have one knee or one hip that hurts. It may be generalized. If both legs are carrying the same amount of weight, then you are going to see it on both sides. Basically what you see is a progressive erosion of that joint or articular cartilage. Remember, between our joints there's a cartilage that sort of keeps them lubricated and allows for safe movement. With OA, okay, what you see is that cartilage basically disappears and you have bone on bone movement, and that's what makes it so painful. Okay? You see those because that joint now has that bone on bone movement. Often what you will see is hypertrophy of those bones. And what you get then is what we call bony spurs or spicules. Okay? And I've heard that people have talked about heel pain with bone spurs. That's because of the irritation. The bone tries to heal because it doesn't have that cartilage there. You get those bony spurs, and then whenever you try to move against, those bone spurs catch. With OA, it can be primary or secondary. Incidence will increase with age. What you typically will see is that most of the time people over the age of 50. But think of some of your high impact athletes, your basketball players, your football players, your baseball catchers, that are using a lot of movement up and down. Typically you see arthritis develop in those folks at an early age. I think Deion Sanders used to play football and baseball. He was a two-sport professional athlete. He had to have hip replacements at the age of 32. And then he went back to play football. But typically in your older folks, joints under pressure, especially the spine, fingers, knees, and hips, and shoulders. Knees and shoulders are probably the most common because of the pressure. People that are obese, they have poor posture, or experience occupational stress are at greatest risk. People that are on their feet, think of factory workers, think of nurses, think of beauticians, okay? Those are people that are more likely to develop OA. All right, we talked about this. Basically, signs and symptoms. There may be no symptoms to pain ranging from mild to severe. Pain is commonly associated with activity, but it's relieved by rest. In other words, one of the things that you'll see is that the more active you are, the more it hurts. You sit down, the pain will decrease. But often what you see is that rest will cause your joints to stiffen a little bit, and you will notice that sometimes when I would stand up, I have to stand here and wiggle just a little bit in order to get to where I can walk. Typically what you're going to see is you may eventually see atrophy of skeletal muscles from disuse around those painful joints. If it does not move, then those muscles tend to atrophy. But that's the worst thing you can do, because if you strengthen those muscles around that joint, it decreases the pain. So typically what we teach patients is to do like quadriceps or gluteal exercises where they crunch their butt, okay, so that you strengthen those muscles. You need to ask about joint pain, tenderness. Look for crepitus. Like I said, if you want to feel what it feels like, you can feel my knee break. Compare your affected and unaffected side. Look at their movements, gait, and noting abnormalities. What is the location and severity? One of the things that you'll see is that sometimes what you will find is that patients will report a pain of 1 or 2, but after movement it may go up to 6 or 7. Okay, so you need to assess before and after movement. How does it affect their mobility and ADLs? Are they using any assistive devices to ambulate, to get around? Is it hot in here? Yeah.
Feels like it's getting colder.
I'm going to have a big hole back over here.
I think today for the first time ever.
One of the things that you will see is with OA, there's no known cure. What we want to do is reduce that pain to a manageable level to maintain as much mobility as possible and minimize disability. Drug therapy, surgery, physical therapy, diet, and education. Basically, diet, like I said, a 5 to 10% decrease in body weight will help tremendously with the pressure that those joints are undergoing. You might have to refer them to a pain specialist if conservative measures are not effective. Now, one of the things that you'll see is that pharmacologic therapy, medications that we use, analgesics, and you will note that there are no narcotics up there. If this is a chronic problem, you typically do not give opioid pain medications for someone that has a chronic problem because it's going to require more and more and more of the medication. Aspirin, acetaminophen, and NSAIDs are your treatments of choice for medications. Aspirin basically reduces inflammation. Tylenol will help with pain. NSAIDs, basically think of those as souped up aspirin. And we're not talking just ibuprofen here. You may be seeing ibuprofen or Advil or naproxen. Naproxen is a leaf, okay? People can take those over the counter. The others that you may see them use are meloxicam. It's an NSAID. Meloxicam is also called Mobit. And then the big gun in the NSAID is called diclofenac. DICLOFENAC. It's also called Voltaren. DICLOFENAC. FENAC. Now, a couple of risk factors you need to worry about to teach your patients with any of the NSAIDs. Do not exceed what the recommended dose is. They can lead to kidney injury and acute kidney failure. They also elevate cardiovascular risks. Typically, they do not give the stronger NSAIDs, and they think very carefully about giving ibuprofen to people with cardiovascular disease because it increases the risk for heart attack and or stroke. Several years ago, there were two more on the market. There were COX-2 inhibitors. And they took those off the market because what they found is that those drastically increased the risk of heart attack. Okay? Now, topicals, counter irritants, salicylates and capsaicin. Okay, the salicylates, like aspartame. Think of these as something that you rub on. I mean, I've seen patients use horse liniment to Lord knows what. But these are topicals. Does aspartame really contain aspirin? No, it contains salicylic. That's a salicylate, but it's not really aspirin in the cream. Okay? But a lot of times what you will see is localized reaction. You may see like blood vessel breakage. Now, capsaicin, what is that? It's the chemical in what kind of peppers? Hot peppers. Okay? Basically what they do is they take the lining of hot peppers and make this medication. Now, how does it work to relieve pain? Well, when your leg's on fire, you don't feel it. Okay? Couple of real teaching points with this stuff. It is recommended that if you use capsaicin, that you apply it with gloves. And wash your hands afterwards, because you don't want to be touching any other part of your body. You don't want to be putting something in your eye or touching your face or going to the bathroom. I've seen that happen.
That was not first of all.
He was not a happy camper because it does not wash off easily. It's an oil. Think of this as liquid pepper spray, because that's what it is.
You're just trading out of pain for another.
You're trading out of pain for another pain. And it does work, because that's what the gate control theory of pain is that there's a theory that says you can only feel pain from one area at one time. So if I'm feeling an irritant, I'm not feeling the pain. Okay? It doesn't really decrease the pain, you just don't feel it anymore. And that's one of the things that we see with a lot of our patients that have OA. You fix one hip and they say, "Doc, now my other hip hurts." No, your other hip hurt the same as it did before. You just don't feel it because this pain is gone. Okay? So it's an irritant. Careful application is very, very key. Now, NSAIDs, we talked about a little bit. Ibuprofen, naproxen, naloxone, diclofenac. The COX-2 inhibitors, the only one that's left is selexipag. It's called Celebrex. Okay? Now, it's one of those things that you're going to see that it's a little tricky, okay? It's what at northeast, what do they do every day to these markers? This one probably won't work. Every once in a while at Northeast, you'll see this when you're taking stuff out of the Pixis or the Omnicell. No, you don't have to give it with lettuce. Okay? Sound alike, look alike drug. It's a salad drug. That's what they term it. Sound alike, look alike drug. Celebrex is a COX-2 inhibitor for OA. Cerebrex is a medication for your head. It's an anti-seizure medication. Okay? So if you're just slurring your speech like a lot of people do when they're trying to pronounce the names of their drugs, or especially their generic names, you might get them mixed up. So be careful. Celebrex is an NSAID COX-2 inhibitor, but what you will see is that it is a med that's very effective for treatment of osteoarthritis. Now, what you need to watch for is dyspepsia, which means what?
Swelling of the belly, air in the belly.
Dyspepsia. Basically, think of this as burping, GERD, diarrhea, abdominal pain, URIs, peripheral edema, GI discomfort. Have y'all seen that new Voice to Men commercial? You got to see it where they're doing the side effect, the singing side effects of this pain. You know, you're gonna be gassy, girl. Yeah.
Oh,
A lot
Lord.
of your NSAIDs will cause flatulence as well. You got to see that commercial. It's great. Now, weight loss and exercise. Definitely. Exercise relief pain and stiffness. One of the things that you will see here, remember with our osteoporotic patients, we wanted weight-bearing exercise. With your patients with OA, we want non-weight bearing. Swimming is a great exercise for them because you move all of the joints, but it's not against gravity. Again, we want to maybe increase the weights around that joint, whether it's range of motion or whether it's muscle sets like quad sets or glute sets to strengthen those muscles, or even that can of green beans, okay, so that you can move that muscle and get it very strong. Heat, the painful joint, or ice. Basically, one of the things that you'll see is that a lot of people alternate between the two, because a lot of people find heat effective, a lot of people find ice is more effective. Canes, crutches, walkers to protect that joint. Now, visco supplementation, this is something that they've tried. Hyaluronan, basically it's like a synovial fluid. And what they've done is try to inject it into the knee joint to put more synovial fluid in there to sort of lubricate it. Thinking about this is like when you get your car, change the oil and greased, okay? So what they do is they put this more synovial fluid in that knee joint to try to lubricate it to keep that bone on bone from being quite so irritating. Studies basically have shown minimal results. So it's not something that they do that often anymore. Yes.
Is it like the orthovis that they use on joints with a series of shots, or is it something completely different? I mean, the orthovis isn't like a ortho shot.
Right. Not really sure. That I'll have to look up. But yeah, they'll do cortisone shots in a heartbeat too. Some of the complementary therapies, acupuncture, nightshade foods. What in the heavens is that? Potatoes, tomatoes, those types of things. Basically, studies haven't shown any difference if you don't eat French fries, or except that it decreases your weight if you don't, which might help. Nutritional supplements or herbal supplements, the nutraceuticals. Probably the one we know the most about is glucosamine chondroitin. And basically what you're going to see is that with glucosamine and chondroitin, it makes a difference with people with moderate to severe pain. With mild pain, or to use it as a preventative measure, it's not really that effective. Okay? Now, one of the things that you need to make sure that you recognize is glucosamine. It's one of those G nutraceuticals. Okay? So it will elevate glucose. It will also increase bleeding time. So if your patient is on glucosamine chondroitin prior to surgery, they need to come off it at least 2 weeks prior to surgery before they remove their hip replacement. Now, any idea what chondroitin is made from?
I think horse or something.
It's a cartilage from what? Shrimp scales. So people that are allergic to seafood cannot take glucosamine chondroitin because it will cause an allergic reaction. Chondroitin is made from shrimp shells. Other things, of course, that I've seen them use: copper, selenium, manganese, and SAMe. 6 of one, half dozen of the others. One of the things that I'll tell you that is an excellent, excellent resource, the NIH has a website that is devoted to nutraceutical and or alternative therapies. So if you want to see what the latest research is, if you go to nih.gov and then pop in whatever vitamin or mineral that you're looking at to see if it works or not, because if you don't want to waste your money, because these things are fairly expensive, that website has probably got the latest research. Okay. Yoga, chiropractic. I will tell you, my chiropractor kept me from having my hip replacements for at least 2 years because I did not want to get my hip replacement at 52. Because one of the things that you know is this joint's going to wear out. Typically what you're going to see now, it used to be every 5 years you had to have it replaced. And now it's 10 to 15. So I didn't want to have to do several hip replacements throughout my lifetime. So my chiropractor was able, between that and the glucosamine, able to keep me from having the replacement for 2 years. But then I kicked myself after I had my hip replacement and had no pain. I'm thinking, why don't I wait so long? Okay. chronic pain problem, because this osteoarthritis will not go away. You may have surgical intervention, but still you're going to have pain in some of the other joints. Basically, one of the things that you'll see is that we want to rest those painful joints, but we still want to exercise them to keep those muscles good and strong. Heat to those joints. Diathermy, basically either physical therapy or a chiropractor can do. It's high frequency electrical currents to generate heat directly into those deeper body temperature, body tissues. Typically, those are done by physical therapists and or chiropractors. One of the things that you'll see is that if you watch Shaq, he has back pain and he has those TENS units, a trans-electrical nerve stimulator. Those work well too, because what you will see is that it stimulates the nerves in the muscle tissue around that joint. And again, because it is that sensation, you no longer feel the pain. What you will find is that the home TENS units, or the ones that you buy at Walmart or CVS, are much less strong than the ones that you see physical therapy and or chiropractic care use. But they are effective. And I will tell you, even if you're having just low back pain, they're not cheap, $50 to $60, and then the pads, but they do work quite well. And I'll try to remember to bring mine in on Friday so that you can try it.
I've got one too. I could bring it too.
Yeah.
They're amazing.
Amazon.
For like $30, and it's tiny little one.
Yeah. But they do work very, very well. Okay, let's do here physical mobility, and then we'll take another break.
I'm gonna have to talk about it.
You want to look at the effective range of motion. Okay, a lot of times what you will see is that range of motion will be decreased because of those bony spurs that they catch, and occasionally will limit range of motion in those patients. You need to perform a functional mobility assessment. Can they get up out of the chair? Can they get up out of the bed? Are they able to take care of their ADLs? Do they need assistance to go to the bathroom? Active, passive, range of motion, those isometric, those are your quadriceps and your butt tensing, okay? Think of that trying to hold them. And the way I teach my patients is just act like you're trying to hold in a heart. And basically they get it. Because if you say squeeze your butt cheeks, a lot of times they don't understand, but you're trying to hold in a big heart, and they get it. Low impact aerobics works well. And it needs to be that low impact, okay? Because remember, this is a painful joint. You don't want to be hopping around on knees with high impact aerobics. And in fact, one of the things that I did, I was the youngest person in this class by probably 30 years. I took low impact exercises for the elderly, okay? And it was one of those things that I can still remember. We had an 80-year-old, we had an 85-year-old, and then 70 years old. And the instructor was saying something about, check your heart rate. I want it up at so-and-so. And I'm thinking, these little ladies are on beta blockers. If you get their heart rate above 120, we're going to be calling 911. So I finally went and talked to her. I said, I want to be careful about that, because they're on this medicine, and they get up that high, they're going to be on the floor. So it's one of those things that, yeah, I made a sacrifice, but it did help with my joint mobility. because sometimes we did chair aerobics and sometimes we did yoga and sometimes we did things, but it's that low impact that you need to do, not hopping around and jumping up and down and stuff. All right, let's take our break.